I have to agree with you completely. All of this technology is complementary without question, and if you can't cross something, you're certainly not getting a lithotripsy balloon across. These are my disclosures. So this is one reason that we need to remain incredibly retrospective as we talk, and introspective as we talk about rotational atherectomy. Not my case, just I found it in the cath lab earlier this week. And obviously, one of the things that we worry about most as it pertains to moving through, sorry, hold on one second. Can we go to the next slide, please? There we go. But this is my case, and rotational atherectomy, obviously diffuse disease, long segments of disease, critically important for achieving the type of results that we're used to achieving. Osteal right coronary arteries, very difficult to accomplish these type of results without rotational atherectomy. Next slide. Next slide, please. So thinking back very quickly, Rotaxis trial dating back to 2011, we know doesn't acutely improve results, stenting results in calcified lesions. That's something we've known about for a long time, because at the end of the day, rotational atherectomy can't differentiate between superficial and deep calcium. And it's deep calcium that modification of deep calcium that accomplishes the results that we are truly looking for over the long term. We know that balloon inflation really pushes deep calcium away, but doesn't achieve improved stent results, and atherectomy techniques may only be modifying or responsible for modifying very superficial calcium, which doesn't achieve the lumen areas that we're looking for durability with our stent technology. We know IVUS can demonstrate frequently circumferential calcium, and all of this is dramatically less compliant. As Dr. LaSalla referred to, dense calcific disease is very difficult to move, and we know by OCT, which tends to underestimate some of the fractures that we can achieve, that we achieve a change in deep levels of calcium that are not appreciated by other mechanisms. So, how are we going to look at deep calcium? How are we going to look at IVSL and its success? Using OCT is probably preferential in terms of appreciating the change in morphology that we've been able to accomplish. But it would be ingenuous not to remember that old Eagles song, "The New Kid in Town." All of a sudden, IVSL is being used for renal artery stenosis, for lead extractions. Balloons, or IVSL balloons, are being put in the aortic position for balloon valvuloplasty, and this is an old movie that I think my kids used to love.
You were right, Roxanne. I never should have left.
Oh, I thought you were dead.
My death was greatly exaggerated.
So to quote an old Samuel Clemens quote, "My death was greatly exaggerated." I think rotational atherectomy is unlikely in and of itself to go anywhere at this point in time. Its necessity when we are unable to cross lesions is paramount, and all of this dates back many years in terms of talking about how we look at severe, moderate, and mild calcific disease. We know that mortality always in pooled analyses, British Medical Journal 2014, meta-analyses, 7 trials, clearly severe calcific disease, higher morbidity and mortality. Even from Mount Sinai's lab, 1-year events stratified by calcific disease. The MACE trial, when looking backwards, interestingly, the difference between severe and moderate and mild is dramatically different. So concentrating on dense calcific disease and its role is paramount. How does this occur? How is this improved with IVSL? Obviously, shockwave therapy changing the morphology of deep calcium with gap emission, with gap transmitters, allows us to address an entire segment of disease. And this paper from 2018 tells us a little bit about whether spotty calcium is seen in shallow plaques, erupted, nodules that are very shallow with calcium in the superficial portion versus the deeper portion. CT scanning, as Dr. LaSala alluded to, many times we don't appreciate on OCT sort of the arc of calcium. CT scanning and micro CT scanning used in research can give us a much more illustrative understanding of that. Calcific nodules, as we've seen all day with OCT, critically important to understand. So the difference in calcific disease plays a central role in terms of how we are treating these patients, and IVSL can get us into most places that we need to be, with the exception of lesions that we cannot cross. Again, everyone has seen sort of the way that IVSL works, and again, as we talked about, all of the major trials looking at 4,200 patients demonstrate excellent ability to deliver stents with minimal dissections and a significant therapeutic benefit that's achieved. And I'm going to wrap up because I don't want to get yanked off the stage here, but leave it to say that this is IVSL is going to go anywhere. It's going to allow us to perform atherectomy in non-cardiac CT surgical sites, and is going to allow us to treat a much wider variety of patients in a more deliberate fashion than we had in the past. I want you to take 1 second to just look at the NCDR data. This is NCDR data that has been accrued over the last number of years. If you look and see the difference between IVL and the volume of IVL as it's gone up nationally, 38% of hospitals around the country have access to this technology. The majority of the IVSL volume is being driven in the top 5% of hospitals, where it's being done in 1 of 6 cases in the United States. Yet there's a difference in the guidelines at this point in time. Rotational atherectomy 2A, IVSL, and other laser atherectomy to be based on the 2021 data. It all goes back to optimal stent technique, including imaging, and that's all I have.